Barflies, it is COPD Awareness Month, and we are so excited to close out this month with a very special episode on COPD care coordination with Krystal Craddock. This is RT Sidebar. Stay tuned.
You always dance. All right, my friend JB, Jonathan Butler's here with his beautiful haircuts. Welcome to RT Sidebar for the last day of COPD Awareness Month. So, JB, we have a pretty special guest. Can't wait to talk to her. I'm going to hand it over to you, my friend.
All right. So we have Krystal Craddock with us today. She is what did Matt call her? She's the godmother of RT Navigators.
That's what it was. The godmother. That's what it was. That's awesome.
Yes. Yeah. So Krystal Craddock, she's been a respiratory therapist for 16 years. Immediately after she graduated, she went working at UC Davis. And that's it. I mean, that's where you spent most of your career, correct?
Correct. I love it here.
All right. So tell us how this journey started with being an RT navigator.
Okay. Gosh. So as mentioned, I started here at UC Davis over 16 years ago as a baby RT. And I worked everywhere within the hospital aside from NICU. I worked in PICU, Children's Hospital, with adults. And I loved it. I love working here. I love my team. I love the physician group I worked with. But about 5 years in, I noticed myself, I recognized myself that I was kind of hitting a wall. I found myself wanting more and wanting to do more with my career, but wasn't sure what it was. So I was spending a lot of my downtime at work, not really doing anything, playing on my phone, and wasn't really productive. And at that time, our medical director at the time, Dr. Samuel Louie, who, if those of you who do not know Dr. Louie, is an amazing person, as well as an amazing RT advocate and pulmonary critical care physician, came up with the idea of creating a COPD educator program within our hospital. He saw at the time that COPD care was fragmented here. We had nurses doing this and RTs doing this and pharmacists doing this, but none of us were really coming together to discuss the one patient and the care continuum for that patient. And so what he wanted to do is create a team of respiratory therapists who would see these patients, provide them with education, work with the team to coordinate the care, make recommendations to the physicians who were seeing the patients and who were managing the patients within the hospital. Most of the times those were the hospitalists and are the hospitalists still to this day. And he went to then the RT director, who was completely on board, and then to the CNO at the time, and introduced this project. And essentially we became COPD case managers. And there was something with the educator word that wasn't, I think within academia, wasn't fitting with our group. And so they at the time said, well, they're case managing these patients, so these will be COPD case managers. A lot of us around the country who are RTs and do this work and are familiar with this work are also known as RT navigators. So the term is used synonymously, just depends on what institution you work at and what you're being called. But we all essentially do the same great work for these patients. So I've been doing that since 2012, and we're still going to this day with our program.
That's fantastic. So did you all start as case managers, or how did that transition work? Because I'm assuming you went out, recruited the best of the best, and then kind of wanted to go from there. And how did that process work?
Well, it's funny. So at the time, we got an email from our one of our managers of the department, and she had asked, anyone interested in being a COPD educator in our department, please, email back and let me know, and I'll give you more information. And so a handful of us, I think it was 8 of us at the time, emailed back and said, I want to know more about this. They're interested. And so we showed up to the first meeting with Dr. Louie, and they were told, congratulations, you're all COPD case managers. And so what we did at the time, it was 8 of us, and the plan was to split the work evenly. There was 3 of us that were on night shift. I was still on night shift actually at the time. And we were going to have 24-hour coverage for these patients. We were going to be providing education at the beginning of their shift. Of course, I'm not going to wake anyone up at 2 a.m. to give them education. But the plan was actually a lot different than what it ended up working out to. So again, 8 of us splitting the work evenly. And then it came to a point where there were a couple of us who were wanting to do more of it full time, finding ways to grow the program and do different things, reach out to DME companies, make connections with them, work with pharmacy. And so we kind of ended up expanding it and growing it. And it's morphed into having 2 full-time FTE positions dedicated to our COPD case management program. That's their whole role here. And then we have a group of 5 RTs within our department who will fill in. So if there's a sick call, and they will fill in. If there's a vacation request, they will fill in. And so we have monthly meetings. We're all on the same page, but that's kind of how it worked out in the beginning. And what happened was, all of us 8 who showed up that day really had a passion and an interest for this patient population. I had worked with this patient population. As I mentioned, I kind of worked all over the hospital here at UC Davis. I had a per diem job and another job at a more rural community that had an elder population, a lot of COPD and pneumonia patients. So I was very familiar with the disease process and the different treatments for it. And so that kind of, it reinvigorated me within the respiratory care profession. I mean, I said I was hitting that wall at 5 years and trying to figure out what I really wanted to do. And ever since getting into this, I have not stopped loving, doing what I'm doing today for these patients.
I mean, it's kind of that standard RT, right? I was there too. You have a lot of downtime between rounds and you're on your phone. But then at some point, like you figure, I don't have the impact in our profession or in the hospital that I wanted going into school, right? So you get that I want more kind of feeling. And I love the way where you went, because my last role in the hospital, I became really good friends of our director of case management. Now he's a big shot at a big system. But I always thought I looked to see who they would hire. It was only RNs or LVNs. And I thought that, respiratory should be represented in that department. So speaking of which, so when you became an case manager, did you have to change departments, or do you get to stay in the respiratory department?
That's a great question. And we're actually still and have always been in the respiratory care department. So just because the title is, case manager doesn't mean we're necessarily within that department. We work very closely with our nurse and social work case managers here at UC Davis collaboratively, which is the whole point of our program, really, is to make sure that all of us are collaborating on behalf of the patient. But we do work under the respiratory care department, and we are still licensed respiratory care practitioners in California. And so under the medical direction of pulmonologist and then the direction of our RT director, we stayed, within our respiratory care department. And we work, as I mentioned, we work alongside with our case management department to care for these patients, but we also will collaborate with them on other patients. We have, patients with trachs or home ventilators that they have questions about and need help with when it comes to DME and all that. And so we're always working with them for the care of any patient who needs a respiratory modality at home and transitioning home.
I really like that. So at what point are you referred to these patients? Is it upon admission, middle of the stay, pre-discharge? Like, when do you get contacted to come see them?
So we actually created a screening tool within our EHR system. We currently use Epic. And what it does is it emails us a list of patients every morning that are over the age of 18, and they meet 3 of 5 criteria that identifies patients. And it really should pick up every patient. And it really does a good job at picking up every patient who's in the hospital and has been admitted for either a COPD or an asthma exacerbation. And so we go through that list and find out who is truly there for that primary diagnosis, or if it's secondary to pneumonia or rhinovirus or whatever's causing their exacerbation. We then go and see those patients. Now we also get referred patients throughout the day. So that list comes every morning at 6:30. But if someone's admitted right now, for example, we wouldn't find out until tomorrow. And as a lot of us know, that it is really important to identify and start planning discharge early. As soon as they're admitted, we're starting to think what this patient might need during their hospital stay, as well as going home. And so we'll get calls and pages from physicians throughout the day, from RTs and nurses from around the hospital throughout the day, saying, "Oh, I just got a patient, giving you a heads up, they're here, and they're going to be on your radar. You're going to need to see them."
That is good to have that heads up, because you have to start planning as soon as a patient's admitted. You got to start planning their discharge. So you get to see them from the start. What happens after that patient goes home?
Goes home?
Yeah, or discharges.
Discharge.
All the way up to discharge. Do you see them in the outpatient setting or follow-up phone calls?
Yeah. So after their discharge, we do provide follow-up phone calls within the week after their discharge to make sure they're still doing okay. After weaning off their prednisone or coming off of their prednisone burst, they have their follow-up appointment. They're taking their medications, especially if we've changed them, and we've sometimes end up changing a lot of patients' medications. We want to make sure they still know what they're taking, they're still taking them appropriately. And then we'll do a follow-up phone call anywhere from 4 to 8 weeks afterwards to make sure they're still doing okay, to make sure they're feeling better than they were when they were here. And then we hope to see them in our comprehensive COPD clinic after that. So we do have an outpatient clinic that came much later. So our program started in 2012. Our clinic didn't come until 2018, but we finally got it. And so we do refer patients to that clinic who don't have a pulmonologist as of yet. If they're at the point where they're in their stage of COPD where they're being hospitalized for an exacerbation, they likely need to follow up with a pulmonologist to at least get their management under control, and then see if we could send them back to primary care and get them feeling better, or see if they need any other advanced therapies. And so we will get to see some of them in our follow-up clinic, which is always so nice because we see them at their worst, right? When they're in their hospital gown or in bed, they can barely ambulate without help, and then being able to see them back at their baseline, almost like seeing them as they want us to see them. They want us to see them as a real person, which we do, but they like, being able to see us, in their normal clothes, and like, this is how I normally am. I'm not normally this sick, frail person. I do have a life, and I want to improve this quality of life. And so it's really nice to be able to see that and see smiles on their faces and not, sick in the hospital bed.
If you're looking for an impact, I would say that is as monumental as you can get of an impact, right? Because in the hospital setting, like I was saying in our last time we met, it's more like a conveyor belt. I treat this patient, they move on, I never see him again. I get another patient, like Lucille Ball when she's in the chocolate factory, to actually get to see them again and see that you were part of their recovery and that they bounced back and now they're part of society again, has got to be good. It's the greatest feeling, and you're heartwarming.
Yeah, it's fantastic. It really, that is what fills my cup. That is, what keeps me going, is being able to help these people. I had one patient I remember who they had their family members in when I went to visit them. It was a gentleman and his wife, and then his sons. And I noticed on the board, how every patient has a whiteboard in their room, and your nurse for the day, your RT for the day, your PT, and all these things, and they have goals listed. And this one patient, I looked at their goals, and I noticed like it wasn't in like the normal nurse handwriting, and I saw that it was it ended up being one of their family members, and I was like, "Oh, who wrote this?" And the sons were like, "Oh, we all came up with different goals," and you could tell it was in different handwriting. And I mean, they were fantastic. It was I took a picture. Actually, I was like, "Can I take a picture, not of the name, but just the goals?" It was just so great. And it was, their goals for the day was to create a one-size-fits-all shoe, to fly without a plane, to catch a tiger by the toe, like funny things like that I just thought were so great. That these are you mentioned the conveyor belt, and sometimes we think of that when they're in the ICU. We get a patient intubated, we extubate them, we send them out. We get a patient intubated, we extubate them. We do great work in the ICU. It's great, but sometimes we get caught up in that, or we forget that these are people who other people look up to and see as their hero. And this father in this hospital bed, their sons were saying, we want you to fly without a plane and catch a tiger by the toe. Like these are like the little things that we sometimes can forget. And so I try to pick up on those little things, and really that inspires, me to do better. This is someone's family member that we're taking care of, and one day our family members or ourselves will be in the hospital and people will be taken care of. And so if we could take the best care of everyone and hopefully, pay it forward, and it's always good to see, and it's good to see that family support as well for that patient. That really drives them as well.
Yeah. Krystal,
Yeah.
you said something that is this little quote. We always look for little tidbits. Fills my cup. And I spent time in the NICU and ICU just like you guys, and that conveyor belt mentality. Okay, that's just how it is. And I had a pulmonary rehab was assigned to me, and I never had a pulmonary rehab assigned to me. I'm like, oh, it's a bunch of older people exercising. It makes no sense to me until I went there. And they're exercising. There's this camaraderie. My pulmonary rehab therapists were the happiest therapists that I had. And I said, why? It was like they fill my cup. And it was interesting. I talked to a couple of the patients. It was so funny. So I go in to just round and see how everything's going. And I walk in, and there are three ladies going, uh-oh, as soon as I walked in the door, and the therapist started giggling. I'm like, what the heck is going on? There's the suit. He's back again. Everybody on their best behavior. So it made me laugh. But then when I started, I felt myself migrating and spending more time in the pulmonary rehab department because it was so much fun. So James put in, how does pulmonary rehab work where you're at? You have extensive clinic afterwards. You have a good transition plan. Where does pulmonary rehab fit in?
We do. We are fortunate enough to have a fantastic pulmonary rehab program here at UC Davis, led by Amy Kazar and her team. And we used to actually have it. It was located within our hospital. Now it's actually located at the same building our outpatient clinic is. And so it's great. I used to actually go over there when it was in the hospital and I was working as a bedside COPD case manager. I used to go over there all the time on my downtime just to say hello to the patients, and they have the best patients in the world, and that's why the therapists are so happy. But we do utilize our pulmonary rehab program. We recommend our patients to that program as soon as we can. Sometimes we have the same barriers as everyone else does to getting patients to pulmonary rehab. One of the biggest ones, I know everyone has said it and everyone hears it, transportation is a big issue, getting patients to pulmonary rehab for those who do not have the transportation. But the other thing is sometimes people hear pulmonary rehab and they think of like rehab, like drug rehab or like an inpatient, like, mental rehab or something. They don't really understand what it means. And so a couple of times when it was located in the hospital, it was pretty nice. We were able to roll some of our patients over there in a wheelchair and show them like the room and meet the RTs, and they can see that it's not so scary. And I remember having one patient one time who was just like, oh, I don't need that. I don't need rehab. And we ended up convincing them to go, and he made fast friends with someone who you wouldn't think, like in a normal everyday, in his normal everyday life, he wouldn't have come across this woman who was in his same class, that they just connected like this. And it got to where, like, even when he would he was in pulmonary rehab, and at one point he did have an exacerbation where he couldn't go for a little while because he was having some upper respiratory issues and having some shortness of breath, and was on prednisone. But he's like, when can I go back? Like, he's like, I want to go now. I'm like, well, you can't yet. Probably next week you can start by going in and just sitting and socializing and having coffee, because that's the other part of rehab. It's not just the exercise and the education, it's that socialization that they get, and that camaraderie within pulmonary rehab. And so he was just so happy to be able to get back into that. But it's an amazing place for patients who didn't think they needed it, or patients who didn't know what it was, and being able to see that it's not scary and that there are people just like them that they can connect with. They have friends that might not have pulmonary disease that they're best friends with, but it's nice to have someone who has that common ground with them and that they can talk to about things that they wouldn't normally talk to their friends or family about.
Yeah, pulmonary rehab, and then COPDers in general. And this is one of the things that I learned when I was in respiratory school, is that COPDers are really good talkers. I don't know why. Maybe it's you're out talking when you're smoking cigarettes or something, but like they are great talkers. And so they can give you some really good stories. I mean, there was so when I was working at a hospital in LA, I was our manager at the time, and I got sent up actually near you now to a sister hospital to look at their pulmonary rehab. And it only took me one patient to realize we need to have this at the hospital I was working at. And it was this little 82-year-old widow, lived at home by herself. She lived in a 2-story house. And she was so decrepit, she couldn't even make it to the second floor of her house. So she was only living on that first floor. So now I got there when she's graduating. So I was talking to her, and she says, she knew she graduated from the program when she made it to the second floor of her house. And I said, well, what did you feel like when you got up there? And she said, I felt like this place is so dusty that I had to dust. And I'm like sitting there choking back tears and like trying not to cry, but the stories that you hear and the successes and just seeing someone come back from being at their worst to like their norm is such a good feeling. And that is an impact that you're not going to get on the inpatient side as much. You can occasionally, but not like that. So, okay, so you're medical director, and once the RT case management program, was there like certain numerics that you were looking at to improve, or did you build those as you go, or what are you looking at for success factors?
Yeah, so what he did first was he looked at our readmission rates and our length of stay. Our readmission rate at the time for COPD exacerbations specifically was 16%, which is lower than the national average, but something he said, we could improve on. And then our length of stay was over a week long for a COPD exacerbation. Yeah, the national average at the time was 4.4 days. Was 4.4 the goal? We don't know. It's dependent on the patient, what's best for them, what they need. But we knew over a week on average was a long time. And so we felt that we could reduce that for sure. And we know that, especially with COVID, length of stay, if we can reduce the length of stay of people who do not need to be here anymore, patients who are waiting for equipment, like they don't need to spend the night to wait for equipment. If we start planning early enough, we can get them out of here on time, because sick people are in the hospital and sick people need to be in the hospital. So that was one of our focus as well. Within the year, we tracked all of the COPD patients that we had seen and looking at their readmission rate and like their length of stay. And we tracked that over the continuum of all the patients that we'd seen for COPD specifically. And we have kept it under 8% for our COPD specific readmissions, and our length of stay.
Say that one more time.
8%, and our length of stay was 5.2 days, and it's still 5.2 days average. So we cut it down by 2 days, which was great. And it's something that we got the data before, we've been tracking it, and then just providing that value is something that we know a lot of the whole healthcare industry in the US is focused on that value efficiency, and how can we provide that as respiratory therapists. So
did you ever get tired of the CFO coming and hugging you for decreasing the length of stay by 2 days?
No, so that and that is specific to our COPD specific readmissions. We know that all cause readmissions are something that still gets looked at. There are so many metrics now. As we all know, we went from fee for service, where we could bill every little thing that we did, even if it wasn't evidence-based. We were doing a procedure and you bill for it and you get reimbursed for it. And it doesn't work that way anymore. And especially under the Affordable Care Act, the hospital readmission reduction programs, we are looking more at providing value to our patients. And I think us as RTs and RT leaders throughout the country should be looking at is how can we help providing that value and those things that matter um, to the healthcare industry in the nation, things like improving value in patient outcomes, reducing length of stay, and that includes ICU length of stay, ventilator length of stay, not just overall length of stay, improving patient satisfaction, reducing infections, so ventilator-acquired pneumonias. So those things that we can do as RTs that bring value and improve outcomes for patients, that's really what we should be focusing on.
You know, I mean, those are two other Medicare programs that are costly to hospitals. You got your hospital acquired conditions with your VAEs, and then you also have your HCAPs. So with your patient experience. So do you measure those as well? Because I mean, now you're looking at being one of the most valuable groups in the hospital, because you're touching on multiple programs and they're expensive.
Yes. So I know specifically we're not on the HCAPs, and we haven't been tracking any of that, but I do know different people within respiratory care who've said that at their hospitals they have added respiratory care within those HCAP surveys so that they can get feedback on it. I think it's a fantastic idea. Just not something I've looked into or have done here or even inquired about, but I definitely think it's important for sure.
It definitely is. I mean, because you know the hospital readmission rate program, that's a maximum of a 3% penalty. I think hospital acquired condition is like 1%, and I think HCAPS is another 2%. I mean, these are big programs or penalties, and it's not even a penalty. Well, it's a penalty, but what they do is Medicare just withholds that money off the front. You have to earn that money, and then you get that fund at the end. I mean, so these are big dollar amount programs that, you know, I think that you have an untapped awareness of, because I can only imagine the extra time that you're spending with these COPD patients is reflected in that HCAPS, but it's just because it's not an actual question. You're probably not measuring it, but I bet you that you have a huge impact in that. And so you should acknowledge that. And I hope you do build that part out, because it just adds more value to you. Because it sounds like what you're doing, and just the fact that your length of stay has dropped so drastically. Yeah. And then also almost about 40% decrease in your hospital readmission rates. I mean, these are big, huge accomplishments. So, and I think there's more to go. So now that you have this winning recipe with COPD, is there any talks about the other readmissions, like the pneumonias, the CABGs, any of those other disease processes that you can impact?
I mean, we have, one of the reasons I love working at UC Davis is because we have so many of those quality and value programs here. We have had a CHF program for as long, or if not longer than our program was. It is more on the nursing and cardiac rehab side that they do that. We've had a transition to care pharmacy program, and they actually made a huge impact on pneumonia readmissions as well. And it was always great working with them too, because they helped us with our COPD patients, of course. Again, it takes a whole team. And if we're trying to figure out what inhalers we want to recommend that are covered by the patient's insurance to address unnecessary readmissions, then we worked with them. And I think, you know, we have the same problems as everyone else. We do have those patients who end up coming back and, you know, have those barriers to their health care and access as other places do and see. But if we can make an impact on those unnecessary readmissions, like those patients coming to the hospital to get refills of their inhalers and coming in and they're short of breath, and we know, like, in the ER, a patient coming in short of breath, or a patient calling, triage with shortness of breath is kind of scary for clinicians that aren't used to treating those types of patients. And for us respiratory therapist and pulmonologist, that's just another Tuesday afternoon, right? That's what my medical director currently will say. He's like, that's just another day in the office for us. So we kind of can recognize those patients and see, what they might need to avoid an unnecessary readmission. And if we're able to make change when they're in the hospital and transition them home with, a better medication plan, following gold guidelines, and making sure it's something that they're capable of doing and able to use, and it's covered by their insurance, then we can hopefully avoid that unnecessary readmission. Some of them are necessary, some of them need to come back, but those little ones will make a huge impact.
Yeah, no, go for it.
Krystal, I love like the passion throughout this episode. Like the amount of times you're like, I love my job, I love where I work, and I love my team, and I love my patients. And I think that's like the most refreshing perspective and voice. Like we're just like so happy to have you on the show today. I like mentioned this to you yesterday when we talked a little bit about this episode, but the concept of ikigai, which is that Japanese word for when you're doing what you love, so your passion, and that overlaps with what you're actually good at, as well as what the world needs, so like a mission, and then something you can also get paid for. So all these things have to line up in the world. And so to me, it's like, check this, you're doing what you're good at, you're doing what you love, and you're doing what the world needs. But then that fourth element really is what you can get paid for. And our audience is primarily RT directors. If they're interested in, let's say an RT director is listening to this episode and that director is interested in starting a program, what advice would you give them so that they can create a similar program? Again, to that last element of what can you get paid for? How do you make this actually like a reality for others to pursue?
Yeah, and that's a tough one because you can't get really paid for it, unfortunately. So it's all about the reduction in the readmission rates, the length of stays, and providing that value. So, and I'm sure many on this call are familiar with Rob Chapman's article in Respiratory Care Journal about value efficiency and respiratory care and moving away from fee for service, because that's just not there anymore. We're billing off of DRGs, and we need to focus as RT directors and leaders on not providing things that don't provide value to patients, that are not evidence-based, and that our RTs are spending time doing, when we can make an impact on things like ventilator-associated pneumonias, ventilator length of stay, hospital length of stay, readmission rates, and so on. And so if you look at another one is improving smoking cessation interventions for patients. That's a huge value thing. So looking at your hospital numbers and admission rates for COPD and their all-cause readmissions or COPD readmissions or pneumonias, is another one under that hospital readmission reduction program. Looking at those types of things and where RTs can make an impact, and kind of advocating for the positions to be placed to do that important work as part of the hospital, because I guarantee the hospital's looking at it, maybe not necessarily thinking about respiratory care and how we can provide that value, but we absolutely can, and have the baseline knowledge and education from respiratory school and working as respiratory therapists for so many years, can help facilitate that. If whether your quality and safety department or your case management department is working on it, maybe there's some ways to partner with them to create a position to be able to address and tackle these things. It's nothing that's like you go in and you check a box and you get paid for it, but making a difference. And it does take time to track those rates and seeing if we're making a difference. And we're working with our population health group here at UC Davis in our primary care offices to address asthma and COPD care, to see if we can make a difference for those patients who are in primary care and not maybe being seen by pulmonary, to see if we can reduce utilization. And so we have created a care manager position. And we've only been tracking since June, but we've noticed that ED visits and last minute healthcare utilization, like urgent care visits and last minute PCP visits, have decreased in that population since we've rolled this care manager position out. And so making sure if you're thinking about this, know what you're doing before and continue to track it, and reassess and reevaluate, see what needs to be changed or what can be done more efficiently to improve those outcomes. But that's the biggest thing. That would be my biggest little piece of advice if you wanted to start a program.
And the passion.
And I agree with you. I agree with you and the passion for sure. I mean, and the fact that you want to have impact on your patient population as well. But I agree with you on the financial side of things. Case management is one of the only clinical departments in a hospital. Not every hospital does it this way, but quite a few that I've worked in, where that department reports up to the CFO, because that's how much of a financial impact this department has on a hospital. And as we all know, healthcare is a business. And then you do have DRGs, but on the private payer side, you also have the do not exceeds, the daily per diems, contracted pricing. So they might not be DRGs, but they're very closely associated, where you're going to max out on a per day charge and you're not going to get more. So really the value is, I mean, nothing really beats length of stay. Nothing beats like all these financial penalties, like the HARP program, where you get like up to a 3% penalty off of your reimbursement if you exceed the benchmark. I mean, those are more valuable to an organization than what you can bill for, every time you do a treatment or whatever. That's just, we've gone away from that. And really what you're doing now is the future. I mean, because this is where you can financially improve a hospital situation by getting involved and increasing your impact and decreasing length of stays and decreasing hospital readmission rates. So I dropped a bill for asthma education in the ER. That might be good and all, but it's still not going to cover the cost of that therapist for a 12-hour shift. It's just not. But if you decrease the length of stay by 2 days for a certain DRG, I mean, you paid for your entire department 10 times over. I mean, really, that's the financial impact that you're having. So I agree with you on that side of things. But it is tough because of, we were fee for service for so long. And, but we have to evolve as a department. And I think this is the way to do it. This is why when I was in my last role, I always wanted respiratory involved in this, because I can see that impact that you have on the business itself, but also the patients.
Yeah,
So,
the patients. Oh, go ahead.
No, please, Krystal, go ahead.
I was just going to say, if we all just kind of look at our patients and focus on patient care, like that's what I kind of tell everyone is that if we even just thinking about the patients and getting them the best care they need and getting them what they need, the numbers kind of follow it. The readmission rates and the length of stay, we're able to get it done, quickly for these patients and efficiently. And you'll just see, if you just focus on those patients, you'll see the numbers. That's kind of how we did it early on. We just focused on those patients and we were like, oh, wow, look at this. So for these patients that we've had, their readmission rate is huge. It's much better. And we've even seen that in our clinic. It just submitted for peer review our outcomes in our outpatient COPD clinic. We were able to reduce exacerbation rates, ED visits, exacerbation rates. We were able to reduce. We were able to improve symptom scores of these patients, so improve quality of life. And then we were able to reduce hospitalizations, not statistically significant. I think your p-value was 0.06, but it was clinically significant. And so even on an outpatient level and, trying to get more RTs to work in that outpatient setting in collaboration with a multidisciplinary team to improve patient outcomes is something that needs to not be overlooked as well. And we're not reimbursed in the outpatient setting, but it doesn't mean we can't provide value in that setting.
So before we go any further, there is an elephant in the room that we need to address. So first off, thank you, Krystal, for being on. This was so awesome. And I know you're very humble and you want to get back to the bedside as quickly as possible. But Krystal, you have a certificate in case management. That is so awesome. Like a respiratory therapist having that is so cool. So I want to give that one, but we have got to address this before we leave. Okay. JB said a bad word a little bit earlier, didn't he?
He did.
Oh shoot, yeah, I did. And then that was actually one of my bullet points too that I was gonna ask. I did.
So your pet peeve
Apologize, Krystal.
is the word COPD. Or tell us why that's your pet peeve, because I think it does remind all of us to be human. So tell us that.
I think oh gosh, I'm a little ridiculous too, so I get that. I just think that it's almost kind of like that conveyor belt thing. We go back to that as another person, another patient. When we think about patient bed 5, and this is patient in bed 5, or the CF or the COPD, I definitely like to say the patient with COPD or the person living with COPD. I'll write that a lot, the person living with COPD, just because so we don't forget that they're a person. And it's not, I get it, like between healthcare providers and, here in the department and saying, oh, the patient in, bed 10 or whatever. But out in like the general care setting in front of clinicians and other family members, like making sure like not to slip and say that, because yeah, I just
You're right. You're 100% right. Dehumanizes the patient, and my eyes are open to that one now, thinking about it that way and then in those terms. So I apologize. I might have evolved in some ways, but not in others. So, I kind of reverted back to my old RT ways.
JB, I just had to pick on you because as soon as you said it, I'm like, wah. Now,
I wasn't looking. Did she flinch when I said it? I think she flinched.
I went like this, and I got a little crack out of Krystal, which was great. But JB, great episode. I mean, you learned a lot, and I to be honest, I think we have to get Krystal back on because there's so much operationally that we could do. But I think we hit on the big points, right? It's good for everybody. Figure it out. Elevate you, and the profession will help elevate patients. This is just right all around. It has your. I can't if I mess it up, Anna. Ikigai. Like it hits all those points, and I think that's really. But how do we do it when so many RTs are burnt out? Krystal's not. So like, there's something there. There's something really tangible there. So what a great episode! I loved it.
Just one last part though. So on RT Break Room, which is one of my favorite Facebook pages to go to, it always comes up. I'm burnt out. I don't want to be bedside. What more can I do? I think this is it. This is your calling, especially if you want to impact the profession and impact your patient outcomes. This is it. This is where it lies. But one last question for Krystal. What does the future of RT case managers look like? If in your wildest fantasy, what would you want to see in the future?
Oh gosh, I would love to see at least one case manager in every RT department across the country. I mean, that's my goal is sharing what we do and kind of helping people who want to create these roles or come up with these roles. And I know Matt Dart was on earlier with you guys. He met with you in Nashville. He's my hype man. If you guys haven't heard the episode, he dropped my name quite a few times. I always tell him, I'm like, my personal hype man. He was one that came up here and to kind of figure out this role and to bring it back down to his organization at UCLA. And they have a great program there now. And I'm always open to sharing anything. And I think a lot of us within respiratory care are like that. But I would just love to see this. It's just so good for the patients. All of whether you're focusing on COPD or another chronic pulmonary disease within your hospital, it is just so good for the patients to have, and our profession to have COPD case managers within your department. It's good for the patient outcomes. It's good for the hospital and the value department. It's good all around. And so if there's anything, that anyone has any questions, I'm always open for people to email me or reach out to me, or others within the field that have been doing this or have done this. I'm sure everyone's open and willing to share. And it's kind of, I think I tell people like it's I mean, it's kind of my thing. Like I'm kind of known as the COPD, or what did Matt said, the godmother of case management. I guess that's my legacy, and I think it's a pretty good legacy to leave if that's what I'm going to leave on this profession and on this planet when I leave.
The fact that you're leaving it open for everyone, though, is the benefit, because anytime you want to start a new program, you have to go and explain yourself and come up with proof. But you've given our industry the proof, right? So you already have the success. You've already created and developed a successful recipe. So now that they can take that to their hospital and show, look, this is the improvements, all these different metrics and how much they've improved and over what time span. And then it becomes more believable than being the first one. But you were the first one. And that, I mean, not only do you have an impact on your patient outcomes, but you had an impact on our profession. And so you will always be the godmother of RT case managers to me now.
And I think there definitely are others. So there are others here, but I think I might just be the loudest and the one who gets up on the soapbox the most, and just really very passionate.
Well, that's a really good segue to how you came on this show. You were actually nominated by a barfly who was listening a couple months ago. I mean, like, this has been months in the making. Jeffrey Davis, he was on once, and he's like, you know who you really need is Krystal Craddock, which is so like kind. That's how this all started. There will be a link in the show notes for other folks who are listening. If you have a story worth telling, you should nominate yourself or a different person with a link in the show notes. Krystal, thank you so much for being on today. This was so refreshing, like, to say the least. Up next, we're going to have Caleb Adams on December 7th, and then Matt Monroe December 13th. And the theme for December is elevating RT. So Caleb's going to talk about interviewing. So let's say you want to go for that case management position. How do you interview for it? And then Matt Monroe, he's at a C-suite level. And so it's about moving yourself up the ranks. So we're really excited for these next coming episodes. And this is our last live recording, just so the barflies know. But you can also register for the live recordings of 2023. Sorry, you can register for those live recordings with the link in the show notes too. So thank you all. This is awesome. Thank you so much, Krystal.
Thank you for having me.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Public and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.